Good morning. In this session, we'll be dealing with the pharynx. Pharynx is a musculomembranous tube situated behind nose, mouth, and larynx. It's a common passage for food and air. Length is approximately 12 to 14 centimeters. Width, it is widest in the upper part, that is the nasopharynx, 3.5 centimeters. On narrowest at pharyngoesophageal junction, 1.5 centimeters. Extends from base of skull to lower part of the cricoid cartilage, that is at the level of C6 vertebrae, where it continues as esophagus. So superiorly, it is bounded by base of skull, posterior part of the body of sphenoid, and basilar part of the occipital bone. Inferiorly, it continues as esophagus. Posteriorly, prevertebral fascia, C1 to C6 cervical vertebrae and intervertebral disc between them, and anterior longitudinal ligament and prevertebral muscles. Anteriorly communicates with the nose through posterior nasal apertures or choanae, through mouth uh, through oropharyngeal isthmus, and to the larynx through laryngeal inlet. So laterally, auditory tube, styloid apparatus, carotid arteries, and last four cranial nerves. Subdivisions divided into three parts. Nasopharynx lies behind the nasal cavity. Oropharynx lies behind the oral cavity, and laryngopharynx lies behind the larynx. You can see here from the base of the skull up to the level of soft palate. This is the nasopharynx. From the soft palate to the upper border of epiglottis, this is the oropharynx, and below the upper border of the epiglottis is the laryngopharynx. So nasal cavity communicates with nasopharynx communicates with the nasal cavity through posterior nasal apertures or choanae. Oropharynx communicates with the oral cavity through oropharyngeal isthmus, and laryngopharynx communicates with the laryngeal cavity through laryngeal inlet. The nasopharynx situated behind nasal cavity and above soft palate, lined by pseudostratified ciliated columnar epithelium. It is the widest and non-collapsible part of the pharynx. Boundaries. Roof is formed by body of sphenoid and basilar part of the occipital bone. Floor is formed by the soft palate. There is pharyngeal isthmus, which is the communication between nasopharynx and the oropharynx. The anterior wall is formed by the posterior nasal aperture, communicates with the nasal cavity. Posterior wall is formed by the anterior arch of cervical vertebrae 1. Here is the atlas. The lateral wall is formed by the medial tergate plate of the sphenoid. So roof and posterior wall of the pharynx form continuous slope. Features: the nasopharyngeal or the pharyngeal tonsil, otherwise called adenoid. So median codical mass formed by aggregation of lymphoid tissue beneath mucous membrane. It's prominent in children and atrophies in adults. Projects forward from junction of the roof and posterior wall of the pharynx. I'll show you all these structures in the diagram. Nasopharyngeal bursa or pouch of Lashka. Mucous diverticulum extends upwards into the substance of nasopharyngeal tonsil from the apex. Pharyngeal opening of artery tube lies in the lateral wall of nasopharynx, 1.25 centimeters below and behind the inferior nasal concha. It's a triangular opening. Tubal tonsil, upper and posterior margin of the pharyngeal opening of the artery tube are elevated by aggregation of lymphoid follicles forming tubal tonsil. Two mucosal folds are present from the tubal elevation. Salpingopharyngeal fold passes vertically downwards on lateral wall of pharynx, contains salpingopharyngeus muscle. Salpingopalatine fold extends downwards and forward to the soft palate, contains levator vela palatini. Pharyngeal recess or fossa of Rosenmuller is a depression behind the tubal elevation. So if you see, these are the features which are going to observe in the pharynx. So if you see in the nasopharynx, nasopharyngeal tonsil, nasopharyngeal bursa, pharyngeal opening of the artery tube, tubal tonsil, mucosal fold, salpingopharyngeal and salpingopalatine fold, pharyngeal recess. In the oropharynx, the palatine tonsil, tonsillar fossa, palatoglossal arch, palatopharyngeal arch, lingual tonsils, the median and two lateral glossoepiglottic folds, vallecula. Laryngopharynx, laryngeal inlet, pyriform fossa, and aryepiglottic folds. I'll show you all these structures in the next few diagrams. You can see here. So this is the nasopharynx. Here you can see this is the nasopharyngeal tonsil, and within that you can see a mucous diverticulum, the pharyngeal bursa or pouch of Lashka. Here you can see the pharyngeal opening of the auditory tube. Behind that you can see the tubal elevation under which lies the tubal tonsil. From this tube you can see two folds are coming, the salpingopalatine fold, and here you can see the salpingopharyngeal fold. Salpingopalatine fold underlies this, underlying this fold there is levator vela palatini, and underlying the salpingopharyngeal fold there is salpingopharyngeus muscle. You can see this is a soft palate. You can see here this is the pessavant muscle, which is nothing but the part of the palatopharyngeus muscle, which forms the pessavant's ridge here. So this approximates with the soft palate to close the pharyngeal isthmus. This is the pharyngeal isthmus, which is the communication between the nasopharynx above and the oropharynx below. So here within the oropharynx, you can see here. So this is the palatopharyngeal fold, which contains the palatopharyngeal fold or palatopharyngeal arch, which contains the palatopharyngeus muscle. Here you can see the palatoglossal arch, which contains the palatoglossous muscle. Here, this is the apex of the tonsillar fossa, this is the base of the tonsillar fossa, this is the triangular tonsillar fossa, and this is the palatine tonsil. Here you can see on the dorsum of the posterior aspect, posterior one third of the tongue, you can see the lingual tonsil. If you observe from above downwards, see this is a nasopharyngeal tonsil, tubal tonsil, palatine tonsil, and the lingual tonsil all together from both sides. They form Valde's ring, which is the first line of defense surrounding the air and food passages. So then you can see here, this is the laryngeal inlet, this is the epiglottis. Between epiglottis tongue, there is vallecula, which is bounded on the median plane by the median gloss epiglottic fold, and on the lateral sides, on both sides, there will be lateral gloss epiglottic folds. Here you can see this is the aryepiglottic fold, and this will be the laryngeal inlet. On either side of the on the sides, on the lateral aspect of the aryepiglottic fold, there will be the piriform fossa. In the next diagram, I will show you the piriform fossa. Here you can see, so this is the laryngeal inlet. You can see this is the aryepiglottic fold. You can see the corniculated and cuneiform cartilages. So this space on the lateral aspect of the aryepiglottic fold is the piriform fossa. So piriform fossa is medially bounded by aryepiglottic fold, and laterally it will be bounded by the lamina of the thyroid cartilage. Here you can see the hypertrophied adenoids. So these adenoids, these are clinically enlarged pharyngeal tonsil, also called as adenoid. So may obstruct airway passage at nasopharynx, resulting in oral breathing, so which typically results in adenoid phases. So may cause spread of infection to middle ear through artery tube. So surgical removal of the adenoids is performed. You can see the opening of the artery tube. So oropharynx lies behind oral cavity, extends from pharyngeal isthmus above to the upper border of the epiglottis below. Boundaries. Roof is formed by soft palate and pharyngeal isthmus, through which oropharynx communicates with the nasopharynx. Floor. Posterior one third of the tongue. Interval between tongue and epiglottis. Then anteriorly, oropharyngeal isthmus, through which oropharynx communicates with the oral cavity. Posterior one third of the tongue. Posteriorly, bodies of C2 and C3 vertebrae. Lateral wall formed by pterygomandibular raphe, mandible, tongue, and head bone. If you see the features, this palatine tonsil. So these are aggregation of the lymphoid tissue, which is located in the tonsillar fossa. So that is especially in the lateral wall of the oropharynx. The tonsillar fossa boundaries. So it's a depression in lateral wall of oropharynx. Largest palatine tonsil. Anteriorly palatoglossal arch. Posteriorly palatopharyngeal arch. Already I have shown in the diagram. Inferiorly posterior one third of tongue. You can see here. This is the tonsillar fossa. Anteriorly palatoglossal arch. Posteriorly palatopharyngeal arch. So inferiorly tongue, posterior one third of tongue. So apex, meeting point of anterior and posterior margins at soft palate. So this is the apex. Palatoglossal arch, mucosal fold runs downwards and forward from palate to lateral margin of the tongue, contains palatoglossus muscle. Palatopharyngeal arch, mucosal fold runs downward and backward to the pharyngeal wall, containing palatopharyngeus muscle. So lingual tonsil, these are the mucous aggregation of the lymphoid follicles on dorsum of posterior one third of tongue. Median and lateral gloss epiglottic folds connect antesurface and edges of the epiglottis respectively to tongue. Epiglottic vallicula, shallow fossa between median and lateral gloss epiglottic folds. You can see here. So this part will be the epiglottic vallicula. Here you can see this is the oropharyngeal isthmus, through which oral cavity communicates with the oropharynx. So these are the posterior nasal apertures through which nasal cavity communicates with the nasopharynx. This is the laryngeal inlet which communicates with the laryngopharynx. Here you can see this is the aryepiglottic fold, and this is the piriform fossa. Oropharyngeal isthmus, arched opening between two palatoglossal folds through which oral cavity communicates with oropharynx. Boundaries: superiorly soft palate, inferiorly dorsal surface of posterior one third of tongue, laterally palatoglossal arch on each side. Closes during declaration, prevent regurgitation of food from oropharynx to mouth. And see, this is the oropharyngeal isthmus. Laterally, the palatoglossal arches, above soft palate, below posterior one third of tongue. Laryngopharynx lies behind laryngeal inlet, extends from upper border of epiglottis to lower border of cricoid cartilage, superiorly oropharynx, inferiorly esophagus, anteriorly laryngeal inlet, posterior surface of the larynx, and then posteriorly bodies of C3 to C5 vertebrae. Laterally thyroid cartilage and thyroid membrane. So features: laryngeal inlet. Laryngeal inlet, inferiorly laryngopharynx communicates with the laryngeal cavity through laryngeal inlet. Bounded superiorly by upper margin of epiglottis, below and behind by interadenoid mucosal fold, and on each side by the aryepiglottic fold. So piriform fossa, also called as piriform sinus or smuggler's fossa. Depression in lateral wall of laryngopharynx on each side of the laryngeal inlet, as I said earlier. Boundaries: medial epiglottic fold, lateral mucosa covering the medial surface of lamina of thyroid cartilage and thyroid membrane. Above, lateral glossy epiglottic fold separates piriform fossa from vallicula. Relations: internal laryngeal nerve and superior laryngeal vagus pierce thyroid membrane and traverse underneath mucous membrane of floor of piriform fossa. I'll show you here. So morphologically, it is deep in ruminating animals and acts as lateral food channel to convey bolus of food during deglutition by side of closed laryngeal inlet. You can see here, this is the piriform fossa. So this is the medial boundary, epiglottic fold. Lateral boundary is by the thyroid laminae and the thyroid membrane. You can see here the internal laryngeal nerve and superior laryngeal vessels coursing from lateral wall to medial wall within the piriform fossa. This one. You can see the laterally bounded by the thyroid cartilage and the lamina of the thyroid cartilage and the thyroid membrane, medially by the epiglottic fold. So sometimes piriform fossa artificially deepened by smugglers and used to hide diamonds. Perforation. Piriform fossa may get perforated during endoscopy. So damage to internal laryngeal nerve. Accidentally ingested foreign bodies may get lodged into piriform fossa. During the removal, internal laryngeal nerve may get damaged. So structure of the pharynx. The wall of the pharynx consists of following layers. From inside outwards, you can see this is the mucous membrane. This is the submucosa. Then the green one is the pharyngobasilar fascia. Then comes the constrictors and the longitudinal muscles. Then comes the buccopharyngeal fascia. So mucosa, submucosa, pharyngobasilar fascia or pharyngeal aponeurosis, then muscle coat, buccopharyngeal fascia or loose areolar sheath. So mucous membrane of pharynx contains considerable amount of elastic fibers lined by non-keratinized stratified epithelium, except nasopharynx, which is lined by pseudostratified ciliate columnar epithelium. Tonsils. So subepithelial collection of lymphoid follicles produce Valdeir's ring. So they have pharyngeal tonsil, tubal tonsil, pelvic tonsil, and lingual tonsil. I have already shown you earlier also Valdeir's ring. Submucous in upper part of the pharynx condenses to form pharyngobasilar fascia. You can see here this is a Valdeir's ring found by nasopharyngeal tonsil, tubal tonsil, palatine tonsil, and the lingual tonsil. The pharyngobasilar fascia or pharyngeal aponeurosis, the fibrous thickening of the pharyngeal submucosa, lines pharyngeal muscles internally. Thicker near base of skull, where fills gap between skull and upper border of the superior constrictor muscles. So this gap is called sinus of Morgagni. So pharyngobasilar fascia or pharyngeal aponeurosis is a fibrous thickening of the pharyngeal submucosa. So lines pharyngeal muscles internally. So thicker near base of skull, where fills the gap between skull and the upper border of superior constrictor. This particular area is called as sinus of Morgagni of pharynx. So there is one more sinus of Morgagni in the larynx. So there will be 4 structures passing through the sinus of Morgagni. We'll come to see in the later slides. Posteriorly, pharyngobasilar fascia forms a pharyngeal raphe into which the constrictor muscles are inserted. The muscle coat, the pharynx consists of 2 layers of striated muscles. The outer layer of 3 pairs of constrictor muscles, that is circular muscles, and the inner layer of 3 pairs of longitudinal muscles. So buccopharyngeal fascia, layer of loose air tissue, covers outer surface of pharynx, anteriorly merges with buccopharyngeal fascia. In upper part of the pharynx, merges with the pharyngobasilar fascia and closes the sinus of Morgagni. Then muscles of the pharynx consist of striated muscles which are arranged in 2 layers. The outer circular layer consists of 3 pairs of constrictors, superior, medial, and inferior constrictor. The inner longitudinal layer consists of 3 pairs of muscles, the stylopharyngeus, palatopharyngeus, and salpingopharyngeus. Constrictors of pharynx from lateral and posterior wall of the pharynx. They form lateral and posterior wall of pharynx. Anteriorly, because the pharynx communicates with the nasal cavity, oral cavity, and laryngeal cavity. So they only form the lateral and posterior wall. So they originate anteriorly and pass posteromedially to get inserted into median fibrous raphe. They are arranged in specific manner. So lower fibers of superior constrictor overlapped by upper fibers of middle constrictor, and lower fibers of middle constrictor are overlapped by upper fibers of inferior constrictor, like flower part. So one flower part inside the other. So there are 4 gaps between these constrictors. You can see between superior and middle, between middle and inferior, below the inferior, and between the base of the skull and superior constrictor. So let us see the structures in the next slides. So embryologically, constrictors of pharynx develop from 4th and 6th pharyngeal arches, hence supplied by cranial part of the accessory nerve through vagus. So except stylopharyngeus, which will be supplied by the glossopharyngeal nerve. So all the constrictor muscles helps in deglutition. All constrictors of pharynx are supplied by fibers from cranial part of the accessory nerve through pharyngeal plexus. Then thyrapharyngeus supplied by pharyngeal plexus and external laryngeal branch of the vagus. And cricopharyngeus is supplied by the recurrent laryngeal branch of the vagus. You can see here the constrictor muscles of the pharynx. The superior constrictor takes origin from pterygoid hamulus, pterygomandibular raphe, medial surface of mandible at posterior end of mylohyoid line, side of the posterior part of tongue. Insertion, pharyngeal tubercle on the base of the skull and the median fibrous raphe. Middle constrictor, lower part of styloid ligament, lesser corner of the hyoid bone, upper part of the greater corner of hyoid bone, inserted into the median fibrous raphe. Inferior constrictor, it is having two parts, thyropharyngeus and cricopharyngeus. The thyropharyngeus takes origin from oblique line on the lamina of the thyroid cartilage and a tendinous band between inferior tubercle of the thyroid cartilage and the cricoid cartilage, inserted into median fibrous raphe. Cricopharyngeus takes origin from cricoid cartilage and inserted into median fibrous raphe. So thyropharyngeus actually pushes the food down, whereas cricopharyngeus acts as a sphincter between the pharynx and esophagus. You can see here, this is the superior constrictor. See the lower fibers of the superior constrictor overlapped with the upper fibers of the middle constrictor, and lower fibers of the middle constrictor overlapped with the upper fibers of the inferior constrictor. Now let us see the gap between base of the skull and upper part of the superior constrictor, called as sinus of Morgagni. Structures passing through it are artery tube, levator palatine, ascending palatine artery, palatine branch of the ascending pharyngeal artery. So between superior and middle constrictor, stylopharyngeus and glossopharyngeal nerve. Between medial and inferior constrictor, internal laryngeal and superior laryngeal vessels. Between lower border of the inferior constrictor and esophagus, recurrent laryngeal and inferior laryngeal vessels. Here you can see the levator palatine, artery tube, the ascending palatine artery, and the palatine branch of the ascending pharyngeal artery. All these four structures passing through the sinus of Morgagni of pharynx. Between superior and middle constrictor, you can see the stylopharyngeus and glossopharyngeus, stylopharyngeus muscle and glossopharyngeal nerve. Here you can see between middle constrictor and inferior constrictor, you can see the superior laryngeal vessels, internal laryngeal nerve and superior laryngeal vessels. So below the inferior constrictor, you can see the recurrent laryngeal nerve and the inferior laryngeal vessels. So Killian's dehiscence you can observe here. So between the thyropharyngeus and cricopharyngeus part, there is a small deficit area. So that is the Killian's dehiscence. So through which a mucous diverticulum containing food can protrude to the outer aspects, that is called Zenker's diverticulum. So Zenker's diverticulum or hypopharyngeal diverticulum or pharyngeal pouch, diverticulum of the pharyngeal mucosa just above cricopharyngeus muscle. Killian's dehiscence, weak posterior part of the pharyngeal wall lies between cricopharyngeus below and thyropharyngeus above. In case of excessive pressure within lower part of the pharynx, mucosa of the pharyngeal wall balloon out through the Killian's dehiscence to form Zenker's diverticulum, may result due to neuromuscular incoordination or spasm of cricopharyngeus muscle. Occurs between two parts of the inferior constrictor because they have different nerve supply. The propulsive thyropharyngeus supplied by pharyngeal plexus and sphincter cricopharyngeus supplied by the recurrent laryngeal nerve. And neuromuscular incoordination, if cricopharyngeus fails to relax when thyropharyngeus contracts, bolus of the food is pushed backward and tends to produce diverticulum. So it might be asymptomatic. So if it is large enough, it causes dysphagia. There will be regurgitation of food, cough. So diagnosis can be done by barium swallow, radiography, or endoscopy. You can see here, this is the cricopharyngeus, this is the thyropharyngeus, this is the Killian's dehiscence, and this is the Zenker's diverticulum. The longitudinal muscles, there are three muscles you can see here, from styloid to the pharynx, stylopharyngeus, from artery tube to the pharynx, salpingopharyngeus, from soft palate to the pharynx, palatopharyngeus. Three muscles. So all the muscles get inserted into the posterior border of the lamina of the thyroid cartilage. So these muscles elevate larynx and shorten pharynx during swallowing. Stylopharyngeus, origin from styloid process, insertion, posterior border of lamina of thyroid cartilage, supplied by glossopharyngeal nerve. Palatopharyngeus arises by two fasciculae, anterior and posterior, from upper surface of the palatine aponeurosis, inserted to posterior border of lamina of thyroid cartilage. Few fibers run posteriorly to form passavant ridge. I have shown earlier. So this passavant ridge forms the posterior border of the pharyngeal isthmus, which is the communication between nasopharynx and the oropharynx. So then salpingopharyngeus, lower part of the cartilage of the artery tube, posterior border of the lamina of thyroid cartilage is the insertion. All the muscles of the pharynx are supplied by the cranial root of the accessory nerve through pharyngeal plexus, whereas only the stylopharyngeus is supplied by the glossopharyngeal nerve. So nerve supply supplied by pharyngeal plexus formed by the pharyngeal branch of the vagus carrying fibers of cranial accessory nerve, pharyngeal branch of the glossopharyngeal nerve, and pharyngeal branches of the superior cervical sympathetic ganglia. Motor supply, all muscles of the pharynx are supplied by the cranial root of accessory nerve through vagus nerve, except stylopharyngeus, which is supplied by the glossopharyngeal. Stylopharyngeus and glossopharyngeal nerve, so they are related to the third pharyngeal arch. So note, inferior constrictor receives additional supply from recurrent laryngeal nerve, that is the cricopharyngeal part of the inferior constrictor. So sensory supply through glossopharyngeal nerve, vagus, pterygopalatine ganglion. So these are the ganglionic branches coming from the pterygopalatine ganglion. So like lesser palatine nerves. And also taste sensation from vallicular and epiglottis carried by internal laryngeal nerve, which is branch of the vagus. And secretory motor supply parasympathetic fibers from lesser palatine branches of the pterygopalatine ganglion are secretory motor for mucous glands of the pharynx. Arterial supply supplied by following arteries: ascending pharyngeal branches of the external carotid artery, ascending palatine and tonsillar branches of the facial artery, dorsolingual branches of the lingual artery, and greater palatine and pharyngeal branches of the maxillary artery. All these arteries supply the pharynx. Venous drainage: pharyngeal venous plexus drains venous blood from pharynx, situated on posterolateral aspect of the pharynx over middle constrictor. Pharyngeal plexus drain into internal jugular vein and facial veins. Lymphatic drainage: so from pharynx drain into retropharyngeal and deep cervical nodes. So deglutition definition: coordinated process by which food is transferred from mouth to the stomach. 3 stages: first stage in the mouth, voluntary; second stage in the pharynx, involuntary; third stage in esophagus, involuntary. So first stage, voluntary stage, involves transfer of food bolus from oral cavity to oropharynx. Mechanism: in this stage, mouth is closed and anterior part of the tongue is raised and pressed against the hard palate by intrinsic muscles of the tongue. So this movement pushes food bolus into the posterior part of the oral cavity. Then soft palate closed down on the back of the dorsum of the tongue. So approximation of palatoglossal arches and upward movement of the hyoid bone. This helps in this movement. Then food bolus pushed through oropharyngeal isthmus into oropharynx. So it's an involuntary stage, involves transfer of food bolus from oropharynx to the esophagus. Second stage. So mechanism: contraction of levator vela palatini and tensor vela palatini, elevation of the soft palate, closure of the nasopharyngeal isthmus. So this prevents entry of food into the nose. Then approximation of the aryepiglottic folds, closure of laryngeal inlet, prevents entry of food into larynx. Then contraction of the longitudinal muscles of the pharynx, elevation of the larynx and pharynx, food bolus pushed downwards over epiglottis, contraction of the superior and middle constrictors and palatopharyngeus, food bolus pushed forward, further downwards into the esophagus. So third stage, involuntary stage, involves transfer of food bolus from esophagus to stomach. Mechanism: contraction of the thyropharyngeus and relaxation of the cricopharyngeus push food bolus downwards. Peristaltic movement of esophagus, relaxation of the lower esophageal sphincter, and entry of food bolus into the stomach. So dysphagia, so it's called difficulty in swallowing. Commonest causes: carcinoma esophagus and cardiac achalasia. Achalasia cardia, it's a failure of lower esophageal sphincter due to congenital absence of ganglionic cells in the minor plexus of esophageal wall. So causes are accumulation of food in esophagus. So pharyngeal spaces, these are the spaces which are located in and around the behind and around the pharynx. So there are 3 spaces: 2 lateral pharyngeal or parapharyngeal spaces, 1 retropharyngeal space. So these were dealt with the deep fascia of the neck. Thank you.